My background is I have my undergraduate degree was in engineering, where I studied biomedical engineering. Then I went to medical school, which I graduated from 31 years ago, 2 blocks from here, Tulane. I did a internship in general surgery, internship in pediatrics, 4 years of otolaryngology, head and neck surgery, and then I did a fellowship in neuro-otology and skull-based surgery, and that's my specialty, neuro-otology. And our field, what we deal with is anything to do with the ear and the skull base, principally hearing loss, vertigo, dizziness, tinnitus, cranial nerve palsy, skull-based tumors, things like that. We're the ones that came up with the cochlear implant, to give you an idea. There's only about 200 of us board certified in the country, and my little niche is I am the vertigo expert. That's what I do. 90% of my patients have vertigo. And so I'm going to talk about some disasters for the inner ear, and here's my talk. And I figured I'd hit, Dr. Orient wanted me to talk about so many different topics. I thought maybe I'll just talk about a handful of things that I think are misconceptions out there. And the first one is concussions. Everybody's heard a lot about concussions with the NFL lately and how they're causing all kinds of problems. And one of the misconceptions is dizziness from a concussion is due to the brain. Vast majority of the time it has nothing to do with the brain, it's the inner ear, because the inner ear is very, very sensitive to concussion. So when you got a brain concussion, you got an ear concussion. Second thing is sound in the inner ear. Earlier we had an allusion to wind turbine syndrome, and I'll talk a little bit about that, but the bottom line is sound can damage the ear, and not just the auditory portion, but also the vestibular portion. And there are sounds that you don't hear will affect you, not to mention there's frequencies above and beyond our ability to hear as a species that will still have physical effects on the body. And lastly, we're going to talk about Hillary Rodham Clinton. Yeah, I know, really. Last year, I wrote a number of editorials basically asking the press to do their job and investigate what's going on with Hillary's health. And it got me involved in all kinds of stuff. And I'm going to give you my own ideas of what I think was going on with her. First of all, concussions. In about up to 60% of patients who have concussions will have dizziness afterwards. And that's pretty prolonged for these folks. In blast injuries is actually up to 80%. So this is a really common issue with these types of problems. Let's step back just a second. What is the purpose to the inner ear? Okay, I'm talking about the vestibular end organ. Of course, you've got the cochlea, which hears for us, but I'm going to talk about the balance portion. There's 5 sensors for balance in each inner ear, 10 total, okay? You've got 3 sensors in the semicircular canals, the superior, the horizontal, and the posterior, which gives us 3 planes of space. Those sensors measure tiny inertial movements of the fluid in those canals. Okay? They measure angular acceleration. The otolithic organs, there's 2 of them, the utricle and the saccule, have crystals on them to give them weight. And they measure tiny little movements of those crystals in response to gravity and linear acceleration. These things are highly sensitive. So imagine what happens when you just get bludgeoned with a hammer, or you're an NFL lineman and you just take a whack on the helmet. All right, the basis for the inner ear symptoms that we see all comes from the reflexes for the inner ear. The first one to think about, and the one that most people are familiar with, is the vestibular ocular reflex. The purpose for that is every time we move our head, there's a reflex to the muscles that control eye movement. Every time we move our head, our eyes are moving in coordination with our head because of a reflex from your inner ear. Purpose for that is so that you maintain stable vision. If that system goes awry, you will get nystagmus, which is jerking movements of the eyes when they're not supposed to move, or they're not quite right, and the symptoms from the patient are they feel like things are spinning, or it looks like things are spinning. They'll get double vision, or they'll get blurred vision. Okay? Next one is the vestibular spinal reflex. These are reflexes to every single one of your postural muscles down your body. And that's because if I turn my head this way, I put a little extra pressure on this foot, etc. It's to maintain yourself upright. Now in lower forms of animals, if they get an inner ear problem, they'll walk around in circles. I don't know if you've ever seen an animal do that. They'll go round and round and round. As a matter of fact, the veterinarians will diagnose inner ear problems over the telephone. They say, ma'am, is your cat run around in circles? Okay, yeah, they've got an inner ear problem. That's about it. Next one is the vestibular colic reflex. It's to the muscles in the neck that attach to the back of the skull. Again, going back to the cats, you see this little cat here has a right inner ear problem, holding his head to the side. If you take the inner ear out on the right inner ear of a cat, they will get nystagmus, they'll walk around in circles for a while, and their head will be kicked over. They'll stop the nystagmus eventually, they'll stop and walk around in circles eventually, but they will keep their head like this the rest of their lives. Okay? Now, people don't do this, okay? At least not to this extent. If you see a person right after they've lost balance function, they'll have their head kicked over just a little bit, and they don't even realize they're doing it. But their eyes will tell them, oh, we got to kick it back over. And what they'll get is they'll get muscle spasms in these muscles in the back of the neck, and they'll be manifested as headaches in the back of the skull. There's the vestibular autonomic reflex, and this is nausea, cold sweats, vomiting, things like that, which are the ones most people are familiar with. But also, it can have effect on your heart rate and your blood pressure. Usually it drives the heart rate up and you get real tachycardic, but it can also drive it down and get bradycardic, and you can get fainting spells from this. It can be so severe in some cases when you get this autonomic stimulation that they actually get anxiety and full-blown panic attacks. As a matter of fact, if you look up at the psychiatric handbook, the DSM-5, for diagnosis of a panic attack, there are 13 different criteria. You need 4 of those criteria to diagnose a panic attack. Well, 8 of those things happen routinely during a vertigo spell. Now, in the bottom, in the fine print on this psychiatric manual says, you must exclude a drug or physiologic cause for this. So theoretically, what they're seeing after a vertigo spell is not really a panic attack because there's a physiologic cause. Okay. Lastly, this last one is not a reflex, but it's a very common symptom we see in patients with chronic inner ear problems. It's brain fog. Think about it from this standpoint. You've got this reflex that's routinely happening all the time. You don't have to think about it. And now it's sending you wrong signals. So you have to consciously think about your balance, how you're going to step, how you're going to hold your head, where you're going to move. And that takes up a certain amount of your conscious ability, your memory, your ability to concentrate. I'll tell you, one of the more common comments I get from my patients when they come to see me is, Doc, I think I'm getting Alzheimer's. I'll drive in the road, the light turns red, I stop there, the light turns green, and then I can't remember where I was going. It's mild and subtle, but it's there, but it's also something that has been identified on neuropsychological testing. And when you fix their inner ear problem, lo and behold, the neuropsychological testing becomes normal. So it's an identifiable objective problem. Okay, this right here is an example of that vestibular spinal reflex. This is a someone who has a left inner ear problem, and their eyes are blinded with some goggles, and they're walking in place for 30 seconds. And what you will see is she's going to slowly rotate to the left side. If she gets to 45 degrees within 30 seconds, it's indicative of a left vestibular weakness or loss of function. As you can see, she goes well beyond the 45-degree point.
Good.
Now, in the next video, I asked her, I want you to pretend you are, because she's not dizzy, okay? I want you to pretend that you're dizzy and you're trying to fake me into thinking that you have an inner ear problem, okay? So this is what a classic malingerer would do. They're going to bounce one way, the other way, almost fall but not quite. They never fall, mind you. And just back and forth. This is of no physiologic significance whatsoever.
Doing great.
I see a fair number of people that are suing somebody over whatever and claiming they have vertigo and dizziness, and this is what they do. All right, so how do we examine the vestibular ocular reflex? And we talk about nystagmus, but my physician colleagues very seldom see it, okay? And the reason for that is it's a reflex. Keep in mind the knee-jerk reflex. You know, you go to hit that knee. If you stiffen up your leg, you're not going to get it. You have to have the leg nice and relaxed. Well, same thing with the vestibular ocular reflex. The way we relax it is we put the patient in the dark. And as you can see, we've got these diver's goggles. So the patient's eyes are in the dark. And on the inside the goggles, we've got a video camera with 4 infrared light sources. So we can see their eyes in the dark. And then we project their eye on a camera, on a television screen behind them. This is my exam room. And actually, every single one of my exam rooms, I have a pair of these goggles. So I can just slap the goggles on somebody in a matter of a couple seconds. If they've got abnormal eye movements, I know they've got an inner ear problem. It's as simple as that. Now, to give you a demonstration of what a normal horizontal vestibular ocular reflex is, here's my daughter right here on the left, and she's going to move from left to right, and you're going to see how the eye jerks a little bit? When you move to the right, the fast phase is to the right. When you move to the left, the fast phase is to the left. Now, I have to say, this is my only child who's actually going to be a doctor. I'm married to a gynecologist. I have 3 kids. She's the only one with any remote interest, but she wants to be a neurologist. So, now this is me, and I'm going a little bit faster. You can see it's a little bit more pronounced. And the faster you go, the faster the eye will move. The slower the eye will move. And again, this is normal. You also have the vestibular ocular reflex in the vertical plane, tangential planes, etc. As I mentioned, causes of vertigo and dizziness, a head trauma, are usually attributed to a brain problem. And this is the general public, and it's also most of the physicians out there. There's peripheral causes, there's central causes, and there's something called uncompensated vestibulopathy, which is a combination of those two. When you get significant damage to one inner ear, the brain will eventually adjust to it, but it takes a long while, and during that time period, things are not quite right. That vestibular ocular reflex is off. Okay, so it's sort of a combination of the problem on the inner ear and the way the brain has not yet adjusted for it. But we're going to talk about these, but one of the interesting things is these are not mutually exclusive. You could have all of these or combinations of these when your head's injured. Well, the most common thing you're going to see after head trauma is something called benign paroxysmal positional vertigo, or loose crystals in your ear. And there's characteristic findings you see with this. You see positionally induced spells of vertigo. They last, there's a 2 to 5 second latency, and there's a 15 to 30 second duration, and it's fatigable. And that if you put that patient in the same position again, it may not happen the second time, okay? And this is what it looks like. This is a video from the epiomniacs, and I have a patient in this chair, and I can put them in any position I want to while I'm monitoring their eye. And what I'm going to do is I'm going to put them in the left Hallpike position, which is stimulating the posterior semicircular canal. And as we're turning the patient to the side, you see the pink canal is the left posterior semicircular canal, and we're going to lay them back. And as we lay them back, there's going to be a 5 second latency. Okay, now that we're back, 1, 2, 3, 4, 5. And look at the eye. And that's going to last for about 20, 30 seconds. And you can imagine if that's jumping up and down, what the patient would be seeing. Okay? And again, if this person was not in the dark with, you'd have a hard time seeing this nystagmus. So you got to have these special goggles to really see most of these. When I taught the residents at the medical school, I would do my Karnak the Magnificent impersonation. Y'all familiar with Karnak? Okay. And I'd ask them, what has a 2 to 5 second latency lasts 15 to 30 seconds and is fatigable? And they would say, And I'd say, absolutely not. It's the chairman's love life. They would never forget it. Anyway, this is what the chair looks like that we have in our office. And like I said, we can put patients in any position. We can check all 6 semicircular canals for positional vertigo. This is labyrinthine concussion. This is microhistographs of the cochlea, the otolithic organs, and one of the semicircular canal sensors. And you can imagine when you get a sudden concussion to the brain, it can stretch these membranes, it can tear them, you can get bleeding in there, and you get damage to the end organ. What you see clinically with the patient is they get suddenly horrible vertigo, dizziness that slowly improves over time. They get hearing loss and tinnitus that usually does not improve over time. It's static, it doesn't alter. But you generally see complete recovery in 6 to 12 months with these folks. Labyrinthine or perilymphatic fistula is when there's a rupture of the inner ear and there's communication with the outside world, which usually means the middle ear. And this is a CT scan of the cochlea showing bone all around it. Here's the middle ear where there's air, and you can see air bubbles in the inner ear. This is a more extreme form. The most extreme form of labyrinthine fistula, they actually have a fracture through the inner ear, a temporal bone fracture. But these folks have an interesting scenario. They may have immediate symptoms or it may be delayed. Their symptoms will fluctuate. They'll have fluctuating hearing loss, fluctuating tinnitus, sometimes it's there, sometimes it's not. They get episodes of vertigo and dizziness that come and go, and they defy all the doctor's expectations. Just when they think they're better, they're bad again. And they may go away spontaneously, but they may persist for years. One of the big tip-offs is the symptoms worsen when they do anything strenuous, like they're working out with the weights, or they're blowing their nose real hard, or anything that changes intracranial pressure or middle ear pressure. Delayed endolymphatic hydrops. Endolymphatic hydrops is the histologic finding we see with Meniere's disease. We see dilation of the cochlear ducts. This is a normal cochlear duct, and this is one that's dilated in the apex of the cochlea. And what you see with these folks is you see fluctuating hearing loss, episodes of vertigo lasting 20 minutes to several hours, pressure in the ear, ringing in the ear. And you have to exclude other causes like the labyrinthine fistula to make this diagnosis. There's another thing called migraine-associated dizziness. This is got some very specific criteria. They have episodes of vestibular spells, headaches, photophobia, phonophobia, and aura. Aura is when you see like spots in front of your eyes before it happens. Migraine as defined by the International Headache Society criteria, and you have ruled out all other causes. Specifically, you have ruled out an inner ear cause. If you find that they've got inner ear problems, you cannot make this diagnosis, okay? Unfortunately, most of the clinicians out there never investigate the ear, throw out the diagnosis of migraine, and kick them out of their office. It is an overly made diagnosis. It does exist, but it's such an overused diagnosis that vast majority of the patients that have been given that diagnosis, we find out they have something else. Lastly, uncompensated vestibulopathy, I alluded to earlier. It's when you've lost vestibular function on one side, and the brain has not adjusted for it yet. And there's a number of different reasons why the brain won't adjust. Most of the time you see adjustment within 6 to 12 months. And those folks don't have spinning spells. They just feel off when they're moving their head. It's like that feeling like when you've had too many drinks of alcohol. You turn your head and things are not quite right. The eyes are a little behind where the head is. And that's exactly what it is. The vestibulo-ocular reflex is just a little bit off. It's still not coordinated. But when they're still, they don't have symptoms. It's only when they move their head. But keep in mind, some of these folks will come in and say, oh, I'm dizzy all the time. But when you think about it, how often do you hold your head completely still? I mean, look at me. I'm moving around. You know, if I had this, I'd be having symptoms all the time. But if you hold still, it should go away. Cerebellar brainstem concussion. This, again, they don't have vertigo. They have vague disequilibrium. They don't have spinning spells. It's associated with a cerebral concussion. But one thing I would point out is all of the vestibular effects, vestibular system is for the most part brainstem, cerebellum, and inner ear. And to get a concussion that will cause a central phenomenon, you have to have a brainstem or cerebellar problem. Okay? The brainstem, for you guys not familiar with it, is God's country. You know, you can't live without your brainstem. It controls breathing and heart rate and things like that. And so if you got somebody, all they've got is dizziness, and they don't have any other brainstem problems or cerebellar problems which go toward coordination, chances are they don't have a central problem. Well, you know, I look back at past conventional wisdom, and right now the conventional wisdom is concussions are caused by dizziness from concussions is caused by central problems. I allude to some of the other things that we've seen in the past. When I was a resident, all the doctors were telling patients that sensorineural hearing loss is due to nerve deafness. That's completely nonsense. You know, 95+% of sensorineural loss is due to sensory deafness. The cochlea is the problem, not the nerve. Positional vertigo was attributed to central mechanisms in 99% of the time. Well, we have found out it's exactly the opposite. 99% of the time it's due to BPPV, these loose crystals in the ear. I ask why. One, it's just an assumption. They made these assumptions, just like we've made these assumptions now, and there was lack of data. Well, we can't say there's lack of data here. If you actually look at studies where they have assessed the vestibular function in patients who have had concussions and complaining of dizziness, this is what you find with various studies. In 1956, Dr. Shuknik looked at BPPV, and he found 10 to 25% have BPPV after a head concussion. Keep in mind, in 1956, we didn't have such great ways to evaluate BPPV. And I can't find a contemporary study, but I would estimate it's probably about 50% have BPPV. If you just measure the function of just the horizontal semicircular canal, anywhere from 32 to 71% have dysfunction of the horizontal canal. If you just look at otolithic, the utricle and the saccular function, you find it's anywhere from 52 to 84% have dysfunction. And if we're looking at central findings on our vestibular testing, it's only 6 to 12%. There's one study said that they saw 60% within 2 weeks that went away real quick. Keep in mind, superior semicircular canal and posterior semicircular canal were never addressed in any of these studies, and that the test for central dysfunction that we use require the patient's active cooperation. So if someone's got a lawsuit pending, a lot of times you see central dysfunction. So it's one of these things I always have a little bit of suspicion about. And why do we see this propagated, this myth kind of propagated? I go to the 3 E's. Economics is number 1. Medicare, Medicaid, private insurances do not reimburse adequately for evaluation of vertigo and dizziness. 2, equipment. Vast majority of physicians out there do not have the equipment to adequately evaluate vestibular patients. 3, expertise. As I mentioned, my specialty, which this is our deal, there's only 200 board certified neurologists in the country, which doesn't sound like very good odds, right? But even among those 200, very few of my colleagues are interested in taking care of dizzy patients. And you may ask why. It's because they will get paid the same for spending 5 minutes taking wax out of someone's ear or an hour and a half taking care of a dizzy patient. So what are you going to do? So most of my colleagues take wax out of the ear. All right, next section here. Sound as a source for inner ear damage, and we're going to talk about a few different topics: noise-induced hearing loss versus acoustic trauma, concussive blast. We're going to talk about wind turbine syndrome, susceptible populations, and Tullio's phenomenon. First of all, has anybody ever heard of wind turbine syndrome? Show of hands. Smattering. Okay. Anybody heard of Tullio's phenomenon? No. Okay. All right. All right. First of all, this is a noise-induced hearing loss and acoustic trauma I hear used interchangeably all the time, and they're totally different things. And I'm talking about not just physicians, but ENT doctors get these two confused all the time. First of all, noise-induced hearing loss is due to persistent exposure to very low levels of noise, okay? To give you an idea, right here in this room with me talking, the sound level is just about 70 decibels. I was measuring in the back of the room earlier. OSHA requires if you're exposed to 85 decibels or more for 8 hours a day, you have to wear some kind of ear protection, okay? And you're talking about the typical factory worker, and this is a picture of your typical guy with noise-induced hearing loss. And what happens with these folks is after exposure for a long enough time, they'll get what we call a temporary threshold shift. They'll have a little tiny bit of hearing loss, a little tiny bit of ringing in their ear. If you've ever gone to a concert and left and you had ringing in your ears, everybody had that experience? Well, if we measured your hearing at that point in time, we would be able to show you have a hearing loss. Within a couple of days, it's probably completely gone and it's gone back to normal. That was a temporary threshold shift. Well, if that happens enough, you eventually get a permanent threshold shift. And it gives us a notch on the audiogram at 4,000 hertz. It's so characteristic that the doctors refer to it as a noise notch. And that will get progressed throughout the years, and it kind of gets its maximum around 10 years afterwards. Now, contrast that to acoustic trauma. Acoustic trauma is a one single episode to a very loud noise, okay? Over here, we're talking about 85 to 110 decibels. Over here, we're talking about more than 180 decibels or so. And there's two types. There's impact acoustic trauma, like metal on metal, and then the more serious of the two, blast noise exposure or acoustic trauma. The blast is more significant, not because of the sound, but because of the non-acoustic pressure wave that precedes the sound. That is much more damaging. In both cases, recovery is, you see, up to about 3 months or so. The hearing loss from acoustic trauma may resemble noise-induced hearing loss, or it may look completely different. In addition to that, you can get rupture of the eardrum, dislocation of the ear bones, you can get damage to the inner ear membranes, etc. Let's back up a second and talk about sound. I want you to think about sound as pressure waves in our environment that we have the ability to sense with our cochlea, okay? The range of the sound spectrum is from 20 hertz to 20,000 hertz. But you've got pressure waves beyond on each end. You've got infrasound and you've got ultrasound. When we test hearing, we only test 250 hertz to 8,000 hertz. And the speech frequencies are roughly between 500 hertz and 3,000 hertz, just to give you an idea. Just because we don't perceive infrasonic or ultrasonic waves by the cochlea does not mean there are no physical effects to the cochlea, the vestibular system, or our bodies, okay? To give you an idea, the US Navy has been working on sonic weapons for decades, and it's mainly in the infrasonic spectrum, and it's mainly been the Navy because the problem with low frequency sounds, they travel long distances. And not something you could use in a city so well because you can't control how far it's going to go. And it's more appropriate for the Navy. It can be bad enough to cause hearing loss, vertigo, dizziness, tinnitus, headaches, solid organ ruptures in the body, hemorrhage, and death. While I was putting together this talk on Thursday, I open up and start looking at the news, and turns out the U.S. is not the only country experimenting with sonic weapons, and there was reports of several U.S. Embassy employees in Cuba that they think were possibly the subjects of acoustic attacks. They had hearing loss, tinnitus, headaches, and other physical effects. There was also a Canadian embassy person who also was affected. This was serious enough that the U.S. actually expelled a couple of Cuban diplomats as a result of it. It's also been used for civilian use, and this is an example of a sonic cannon used in Pittsburgh in 2009. These have also been used in York, Ferguson, Baltimore as crowd control. This is the first time used in the U.S. in the G20 summit in 2009. And watch what everybody does when they turn on the cannon. They run away and put their hands on their ears. Now, one of the limitations, this is obviously in the sound spectrum. It's high frequency sound, so it can't go very far. And it's stopped by walls and stuff. So if they put their fingers in the ears, they can basically stop it. But at the same time, too, if you've got your fingers in your ears, it's hard to do much damage as a rioter. And you see, they've just moved a far enough distance away to where it's not giving them any trouble. So you have to get the source up close. Let's talk a little bit about the pathophysiology of noise-induced hearing loss versus acoustic trauma. Noise-induced hearing loss, like I said, it's lower levels of noise over many, many years, and it's felt to be metabolic exhaustion is a leading theory for that. Acoustic trauma, especially blast, is due to physical disruption of the inner ear membranes. And again, the supersonic wave that precedes the hearing, the sound wave, has 10,000 times more energy to the inner ear. And there's a little diagram showing, the instant that the explosion happens, there's this huge shift in the waves. Sound is 340 meters per second, but it's not as fast as instant. This is a battleship with cannons going, and you can see the water around it that has been dispersed by that supersonic wave. If it can do that to the water, can imagine we can do the little water in your inner ear. Sound also affects the vestibular system. And this is another misconception I see with a lot of colleagues. Even if you're deaf, sound will affect your vestibular system, assuming you have a vestibular system. And there's been some interesting studies showing sound-induced vestibular stimulation in deaf people. We can also do something called vestibular evoked myogenic potentials. We can put sound in the inner ear and measure vestibular effects. Which leads me, I'm going to talk about it in a second, but wind turbine syndrome is unlikely propagated via the auditory system. We talked about all these reflexes from the vestibular system. Well, there's really not any reflex from the auditory system unless you get to really loud sounds. Then you get an acoustic reflex. But at the lower levels, all it does is propagate to the brain, I'm hearing that. Wind turbines operate in the infrasonic to very low sound perception level at 15 to 50 hertz. They will not necessarily be sensed by the cochlea. Some people will hear it if they've got good hearing. But they will show effects on the utricle, the saccule, and the semicircular canals, especially in susceptible people. And that's what I'm going to talk about. Just to give you a background, the definition from Wikipedia for wind turbine syndrome is a psychosomatic disorder primarily caused by anxiety, generated by heightened awareness of turbines, the nocebo effect, prompted by proponents of the idea that wind turbines have adverse health effects. All right, so that's kind of like the mainstream view of wind turbine syndrome. The symptoms, there's several symptoms related to the vestibular system: vertigo, dizziness, tinnitus, off balance, nausea. They also have disturbed sleep, headaches, sense of quivering or vibrations, nervousness, rapid heartbeats, nausea, difficulties with concentration, memory loss, irritability, and anger. Sounds kind of familiar, doesn't it? Okay. The interesting thing I find is all of these wind turbine syndrome patients all have the same symptoms. And guess what? When they move away from the wind turbines, it all goes away. So it makes you wonder. Now, one disclaimer, I have never seen a wind turbine syndrome patient. And if anybody knows one, please send them to me because I would like to evaluate them. I would like to look at their vestibular system. I have seen tons of patients who I think are potentially susceptible to wind turbine syndrome. First, there's anatomic susceptibility. There's a whole wide range of inner ear disorders, mostly lacking bone or malformed bone, that make people more susceptible, more sensitive to noise. The prototypical one is one that I've kind of made my fame on, is superior semicircular canal dehiscence. For you guys who are not familiar with this, is basically a hole in the top of the superior semicircular canal. This is the brain here, And normally you're supposed to have bone over the top of the upper balance canal there, and in this patient's case, they're missing. And so any little tiny change in intracranial pressure gets transmitted to their inner ear. These folks will get dizzy with certain sounds that don't bother any of us. They will hear all kinds of, they've got like superhuman hearing. They will hear their own heartbeat. They can hear their own eyes move. They will hear all kinds of things that none of the rest of us can. And audiometrically, we can test their hearing at these superhuman levels, if you would. If you go in and put bone over that area, like I did in this particular patient, guess what? It all goes away. Okay? They're born like this, and it represents about 1% to 2% of the population. Now let's assume there's 1,000 people living next to wind turbines. 10 to 20 of these people are going to have this particular disorder, superior semicircular canal dehiscence. I would not expect any of these patients to want to live by wind turbines. And I would expect if they moved away, things would get better. Now, I'm going to show you an example of Tullio's phenomenon. Do we have the audio up for this? Okay. All right, this first one is an audiometer, external audiometer is going to introduce to this patient's ear. And you can see the eye move up and to the left. You see kind of pulse tones kind of bobbing up and down. These patients have superior canal dehiscence syndrome, by the way. This one's going to be a hum the patient does himself, so this is an internally generated sound.
Yeah. Okay, all right, keep your eyes wide open. And do you want me to make the sound, or you want to make the sound?
No, I have to do it.
Okay.
So he's going to make the sound.
Get the right pitch.
Okay.
You see his eyes go up and to the right. Watch when he does a sustained hum.
Okay. Try again. Can you try to hold that pitch?
Sure.
Okay, got it.
Whoa.
All right. Well, I don't know anything about wind turbine syndrome. Like I said, I don't have a patient with wind turbine syndrome. I did a Medline search on wind turbine syndrome. This is the result, 7 papers, okay? So there's really almost nothing out there. And of those 7 papers, all but 2 of them are basically just people postulating, I think it might exist. Oh no, it's just people with political opposition, etc. The only 2 that aren't about that, one's about badgers having chronic stress from wind turbine syndrome, and the other one's about the endangered Indiana bat. You can imagine bats having issues with that. So there's really no real research. And the unfortunate thing is, does anybody in this room expect there will be research on this? I mean, who's going to fund it? Is the energy industry going to fund it? Is the government going to fund it? Yeah, that's about the only group. Although they're going to hit at them with individual suits, I think. When it comes to wind turbine syndrome, I go back to my superior canal dehiscence patients. Prior to us identifying them in 1998, they were considered to have a psychosomatic issue, and they were sent for psychiatry. There was actually a Grey's Anatomy episode where somebody had it, and they were being admitted to the psych unit, and the doctor says, wait a minute, they may have superior canal dehiscence syndrome, and they saved the day. We also had a disorder in my field called globus hystericus, where people would come in saying that they felt like they had something in their throat. And we'd look back there and there was nothing in the throat, just psychosomatic, they're crazy, anxious patient. And what it was gastroesophageal reflux, kind of causing a little light burn to the back of the throat. And they do quite well for treatment of gastroesophageal reflux. But I also will point out there's been no vestibular studies on any of these patients. It's all been assumed this is auditory effect. And like I said, I don't think there's anything auditory about any of this. My personal opinion is I think it's a mixed bag. I think you have some of these folks that have a susceptible situation, like the superior canal dehiscent patient, and they're truly having problems. Do I think there's some psychosomatic people out there? Sure. I also think there's probably some malingering out there, people just looking to sue the energy company to make some money. So I think that it's a mixed bag. Again, I go back to the 3 E's. You know, economics, there's nobody going to fund research on this. There's not enough equipment out there, there's not enough expertise, so it's going to be with us for a while. Lastly, we're going to talk about Hillary's health problems, okay? Just to refresh your memories, she had two separate episodes of blood clots spontaneously forming in her lower extremities. She had a concussion. She had double vision after the concussion and wore prism glasses so that she can get single vision, okay? She had a lateral venous sinus thrombosis, which is a blood clot in one of the major veins in the brain. The media portrayed this as secondary to the concussion as a result of it. It don't happen like that. She had that long before the concussion. It's just once she had the concussion, they scanned her and found it. As a matter of fact, it might have been why she fell and got the concussion. She's had multiple spells of incapacitation with relatively quick recovery, and she had these coughing fits. Well, I wrote a bunch of articles, and along with Dr. Orient, we kind of jumped on this, asking the media, hey, you know, we're not going to say she's got anything weird or bizarre, but what are the consequences of her concussion? What are the consequences of her lateral sinus thrombosis? I mean, these are potentially both life-threatening problems. And even if they're not life-threatening, they both are significantly life-altering for a lot of patients and can cause significant cognitive problems. And we couldn't get the media to pay attention to us. Let me step back a second, just kind of go through the cerebral venous sinus anatomy. The vast majority of the blood from the brain returns back through 2 lateral sinuses to the jugular veins and back to the heart, okay? Obstruction of one of those sinuses, if we just blocked one side, suddenly all the blood has to go through the other side. This is very analogous to someone breaking down on the interstate. You got 2 lanes on the interstate, 1 lane, guy breaks down on, everybody's got to go through the other. What happens? Cars back up. Problem is in the brain, when blood backs up, you get increased pressure in the head because the brain can't swell out past the skull, so the pressure just goes up. And there's some significant effects from the increased pressure. This is not controversial. This is well known, well established, been known by the medical community for decades, okay? If you get propagation of that clot across the side here, over to this side, and you get obstruction on the other side, the mortality is very high because the pressure goes through the roof and the patient will herniate. Again, this is not controversial. That's why they're aggressive with using the blood thinners like Coumadin to try and prevent it from propagating. Well, what's the natural history of this? With the Coumadin, you can get the thrombus to stabilize to prevent it from propagating. It may partially recanalize, and you get, as it develops into like a scar, you can get growth of some blood vessels through it and get some return of the blood flow. It almost never completely dissolves like they kept portraying in the media. As I said, the thrombus may propagate and you can get some more severe sequelae. But in either case, some degree of elevated intracranial pressure persists, and that will fluctuate. The symptoms from that, headaches, dizziness, hearing loss, tinnitus, visual problems, it can also cause a lot of the other stuff we've seen with Hillary. Well, it can also affect the cranial nerves. And the most common, does anybody know what is the most common cranial nerve palsy caused by elevated intracranial pressure?
Sixth nerve.
Sixth nerve. You must have read my slides. No, it's well known, well known. It's because of the sixth nerve's course through intracranially and then extracranially. And it goes to the lateral rectus muscle, which pulls the eye to the side. And so in these folks, they tend to have the eye go the other direction. Because as the brain kind of swells and pushes down, it tugs on that nerve. And you can get typically unilateral, but it can be bilateral sixth nerve palsy. And other nerves can be involved as well. It's just this is the most common one. And I think about Hillary with her chronic coughing. I have seen patients who've had intermittent vagus nerve palsies from elevated intracranial pressure. I always wondered, Was it the vagus nerve causing her some discomfort and the chronic cough? Hillary had some eye problems, and you can see this is a video of her interview with Diane Sawyer back in 2014. And back then, you could see some subtle problems with her eye. And I want you to pay attention. The media tries to cut away from it and protect her, but pay real close attention to this. Look at her left eye. It's very subtle. And if I have to, I'll play the video again.
Explosive interview with former Secretary of State Hillary Clinton making headlines tonight. Diane asking about medical issues after Republican strategist Karl Rove suggested she may have suffered traumatic brain damage after a fall in 2012.
How is your health?
It's very good, thank you.
How serious was it?
It was, I think a serious concussion.
But you had trouble with vision.
Because
They tried to protect her.
of the fall. I had double vision.
So no lingering effects.
No lingering effects.
I got you. Do y'all need to play? Was it subtle? Do I need to play it again? No, seriously though, she really did have some funny eye movements, especially I think it was in some speech she gave in Philadelphia. But this was just too rich to exclude. After that episode in Philadelphia, we actually, along with Dr. Orient and APS, we sent out a flash poll to doctors, and we got 250 doctors to respond, asking, do you think Hillary has abnormal eye movements? And it was like 3/4 said, oh, absolutely. And this poll made national news, and it got picked up by Drudge Report and was sent all over the place. And Dr. Orient was sharing with me yesterday that it's like their press release agency says this is the biggest one they've ever had in their history. And this is a little picture of the prism glasses Hillary was wearing. Anyway, as far as treatment for elevated intracranial pressure, the big thing is you have to make the diagnosis. And I don't think Hillary's ever going to get that diagnosis because she's on Coumadin. She's had 3 spontaneous blood clots. And I would want to see the cojones of the physician that's willing to take her off of blood thinners and do a lumbar puncture, And it's an invasive procedure that has significant bleeding associated with it. My interest in elevated intracranial pressure started with, we got a non-invasive test for intracranial pressure that we've been dealing with for 10 plus years. It's called the Marchbanks device, or tympanic membrane displacement analyzer. And I have to tell you just an interesting little story. There's only 5 of these in the country, and we have 1 of them. The first group to get it was NASA, because NASA wanted to measure intracranial pressure in the astronauts in the space station. And it turns out the #1 health risk to the astronauts is elevated intracranial pressure. Of the, I guess it's about 80 astronauts have gone up, half of them have had visual changes from the elevated pressure, and there's 3 on permanent disability because of it, permanent visual changes. We were the second group to get the Marchbanks device. The third group was Dartmouth University, and the 4th one, you'll never guess, was obtained by NASA because they forgot they bought the first one. True story. I got this straight from the guys at NASA. But don't worry, it's only $35,000 of your tax dollars. And I know this because they called me a few years ago saying, Dr. Gianoli, we hear you have a Marchbanks device. And I said, yeah. He said, well, how many patients have you tested? And I said, well, somewhere over 1,000 or so. He said, oh, wow, and I've heard you've done some lumbar punctures to correlate with these. And I said, yeah. I said, how many have you done? Oh, probably 500 or 600 or so. He said, oh, wow, can we mine your database? So they mined our database. Turns out, how many did they do? And they got it before us? They did about 24, okay? Anyway, so from mining our database, it proved the safety and efficacy of the device. So they have also not the 4th one, but also the 5th one, which is a miniaturized version to go up in the space station. Anyway, but there's lots of things you can do for elevated intracranial pressure, and I think this is something that's going to be a much more common diagnosis made in the future as we see our waistlines expand and sleep apnea become a bigger problem. But the main thing is CSF pressure reduction. avoidance of straining diet, diuretics, carbonic anhydrase inhibitors for the severe cases. You've got surgical things you can do. You can do shunts, and then you can do local things for the eyes and the ears. But as I mentioned, I'm not sure anybody's going to be doing an LP on Hillary in the near future. Lastly, I would conclude just to let you know, okay, when the majority of patients with dizziness and vertigo after concussions, it's due to their inner ear, not their brain. I mean, it can be a brain problem too, but most of the time it's the inner ear. Sound can be pathogenic to us, especially for susceptible populations. And lastly, Hillary Clinton most likely has medical consequences of elevated intracranial pressure. And that's it. Thank you.
What is your experience with ischemic brainstem strokes?
You know, I don't really deal with them so much other than dealing with the consequences afterwards. I'll deal with them having dizziness and vertigo, but for the most part, that's the neurologist dealing with it.
I've had one. It seems that there's something through the feet. If you go barefooted and you walk around, you're much more stable and it's not as affected.
There's three main sensory inputs for balance. Number one is your pressure touch sense. And you think about where do we touch the world? The bottom of our feet, okay? That's actually the most important sense for balance. Second most important is inner ear. Third and least important is vision. They get coordinated in the brain. The spinal column output is to the muscles of the legs. You have to have good skeletal structure to hold yourself upright and strong legs as well. You're welcome. But that's a huge one. I have to admit, that's the one I least like to see because there's usually not much you can do about it.
What is the non-invasive way to measure intracranial pressure? There is one?
Yeah, it's called the
Marchbank?
Marchbank's device or tympanic membrane displacement analyzer. Some people call it the cochlear cerebral fluid analyzer. Basically, we go through the ear. We put a sound, two things we do. One is we just measure pulsations of the ear, okay, and which gives us an idea of heart rate coming up or pulses into the brain. The second is based on the acoustic reflex. The stapes sits in the stapes is the last ear bone, and it sits in the oval window, okay. If the pressure is normal or low, it'll be kind of sitting in it a little bit. The acoustic reflex, when it pulls that stapes, will pull it out. If the pressure is high, it'll be pushed up, and when you get the acoustic reflex, it pulls it down. So you get a positive deflection, it usually means normal pressure. Negative deflection, it means high pressure. And it's not perfect. You need to have a normal inner ear, a normal middle ear, a normal acoustic reflex, which knocks out a lot of my patients when they're coming to my office. But for someone who's otherwise got normal stuff, it's a very good test.
And they're using that on the astronauts?
Yes.
To measure, okay. Thank you.
You mentioned the crystals in the ear, and you didn't talk much about that. I have two daughters that have vertigo, and their treatment was exercise. It seems to work, so they must have had the crystals.
Yeah, well, it could be. By far and away, it's the most common cause of vertigo and dizziness we see. It's so common that I will tell you virtually everyone will have it at some point in their life if they live long enough. You can see in all age groups, but it gets more and more common the older we get. It's so common in the elderly that I would tell you over the age of 70, probably if I took 10 people over the age of 70 and randomly checked them, I would bet 4 of them have it, don't even realize they have it, they just think their balance is bad because they're getting old. That's how common it is.
Well, would the exercises possibly help some of the other forms of vertigo?
Oh, well, it depends. If you've got one of these things we call uncompensated vestibulopathy, exercise or specific exercises for the vestibular system basically kind of retrain the brain. Okay, this is how it feels to turn my head side to side and that kind of thing. Now, specifically for the crystal problem, there's a series of head positions we put the patient through to get the crystals out of the place where they're causing problems into a place where they won't. And there's a number of different maneuvers we can do. It's a single episode. It's not like exercises, but it's a single maneuver we do, and it works. It's like 90% effective.
That sounds like what they did.
Yeah, that's probably it. There's a bunch of different ways, and actually that device that I showed, it's one that you can do it on the device as well, so it's not just diagnostic, it's also therapeutic, and it can put the patient, you can take care of not just, the typical Epley maneuver that John Epley devised is strictly for the posterior semicircular canal. But you've also got the horizontal semicircular canal and the anterior semicircular canal that require different sort of maneuvers.
Do you think hyperbaric oxygenation therapy can help with some of these problems?
You know, probably in in some of the labyrinthine fistula cases, it would be of some benefit. But most of the peripheral stuff, I don't think would make much of a difference.
All right. And if there were to be a study of wind turbine syndrome, maybe you could participate in that?
Oh, I'd love to.
Yeah.
Yeah, I'd love to see some vestibular studies on them. I'm just curious about it but the big thing I would tell them is don't look at it from an auditory standpoint, because it's not hearing that's driving any of this. There's no way hearing is driving it. And that's what all of the people saying this is psychosomatic saying, there's no way hearing can cause this, and I would agree with them. They're right. It's vestibular. It's not just the force, but it is the frequency. If you look at these superior canal dehiscence patients, high frequencies won't bother them. They won't get that tulios from it. It's the low frequencies that do it. And the reason is because you get a bigger excursion of the stapes with the lower frequencies. When we talk about how we measure sound, it's on this what we call A-weighted scale. And in the A-weighted scale, it really de-emphasizes how much sound and pressure is in the low frequency spectrum because we're not as sensitive to that from the cochlea. So it's also pressure, yeah.
Years ago, I heard that a silent adapted ear was up to 80,000 times more sensitive to detecting sound than a non-silent adapted ear. Does that ring true to you?
I'm not familiar with that.
With sound adaptation?
Yeah.
Yeah, I haven't been able to find much on it.
You know, the one thing I will tell you is in the noise-induced hearing loss patients, there's the ones that have been exposed to more sound are actually somewhat protective,
Right.
in that there must be some sort of adaptation there,
Yeah,
but I don't know much about it.
that was going to be the follow-on, is the silent adapted ear more sensitive to damage from sudden noises?
Well, I can tell you as somebody who works in a factory for 10 years, and let's say they got a little tiny noise notch, and they and you, or somebody who has not worked in that environment, both get exposed to loud noise, they're going to be less affected than you, whatever it's worth. The acoustic reflexes actually get initiated too slow to be protective against noise. I know it used to be thought that those reflexes with the muscles in the inner ear would blunt that loud sound, but the problem is they get enacted too slow. It's now believed it's more of just like a tuning device. The duration is the other thing. It's not just how loud, it's how long.
Thank you, Dr. Gianoli. Thank you very much. It's lunchtime, so let's go have lunch.